Well, I think we're going to get started. Welcome, everyone. This is, again, Research and Education Week. During this week, this is going to be a vibrant exhibition of all the scholarly activities and achievements of our faculty, staff, and trainees across the full array of disciplines we have here. And this year's theme is Frontiers in Innovation, focusing on science-based discovery across the spectrum of diverse communities. And we're excited to display over 350 posters. And at 1 o'clock this afternoon from 1 to 3, we hope you're going to join us for the poster session. And I wanted to finally give a sincere thanks to Faiza Gillam and Nathir and Kasten Hildebrand for their work in setting all this up. And then just a few announcements. All abstracts for the posters can be viewed in the ebook and the PDF, which can be downloaded from the Research and Education website. Secondly, all research and education events, please pick up the brochure in the back so that you have it. And lastly, during the Q&A for this lecture, please use the microphone so that folks who are online can hear you. So it's my pleasure to introduce Dr. Vanessa Carey, who is going to speak on long-term horizon, challenging the modus operandi of global health and development. Dr. Carey is the co-founder and CEO of Seed Global Health, a nonprofit organization which helps provide nursing and medical training support in resource-limited countries. She's a critical care physician at Mass General Hospital and serves as the Associate Director of Partnerships and Global Initiatives at MGH. She directs the Global Public Policy and Social Change Program in the Department of Global Health and Social Medicine at Harvard Medical School, developing research and training on long-term health and system protection and function. Please join me in welcoming Dr. Carey.
Thank you very much, Dr. Bradshaw. And good morning, everyone. Thank you for joining, coming to hear a little bit about the work we're trying to do. And so, I'm going to talk about a number of things, but what I really want to talk about is sort of challenging a status quo and thinking a little bit about how we can take an urgency of now to begin solutions that maybe take a long time to actually see the fruits of, but that there is an urgency to getting us on kind of a right path if we're going to start to close some of the fundamental gaps that exist in health. So, I want to open with sort of a bigger theme that Seed Global Health is trying to embrace in all the work that we do, which is that we're trying to change the value of how people view health, just fundamentally, to get people to realize that health is fundamental to everything we do in the world and everything that we strive to do. And I think if we stop seeing health as a social investment and we start seeing health as something that we need, like food or water, and just is, that maybe then we can start to make the kinds of investments we need, not only in our personal decisions, but in the kind of investments that we start to see in health going forward and different types of health. And one of the reasons that we know this to be true is that there's actually very strong data that starts to back the role that health plays in certain aspects of our lives. So there's a microeconomics to health. And there's data that shows that actually the personal and household costs are linked to poor health. So there's very clearly, there's a loss of personal productivity if you are sick and you are an hourly wage earner. I can tell I'm exhausted. 4 a.m. start, so try to stay coherent here. Is that there's a loss of personal productivity if you can't go to work and if you can't actually be able to participate in your daily life. There's a direct loss of income often with that. Your income may be because it's out-of-pocket expenses, because you're paying co-pays, or it may be that you are, participating in unhealthy behavior. You're spending $15 on a pack of cigarettes or on excessive alcohol or on risky behaviors. But there's very direct costs that are transactional that can affect one's well-being on a microeconomic level. There's studies that support this, though. So, for example, in Zambia, there's a study that was done in Lusaka that looked at what happens when the main breadwinner of a family dies of HIV. And it turns out when the main breadwinner of a family dies of HIV, 80% of those households experience a 67% decline in income. 67% of households have an 80% decline in income. 61% of households actually have to move to cheaper housing. 39% lose access to running water. And 21% of girls and 17% of boys stop going to school. On a macroeconomic level, health promotes economic stability. More data. As we know, and it's been shown, and it just intrinsically makes sense, if you have a healthy population, you have a healthy labor force that can contribute to the well-being of the country's GDP and markets and people who go out and buy things, and there's an ability to actually grow your economy. Health also keeps houses above or below the poverty line. So it turns out that 25% of households that have some member affected by non-communicable disease will fall below the poverty line, and 50% of households will suffer catastrophic costs that put them below the poverty line if someone in the family is sick with a malignancy. In East Asia, it turns out that countries that made major investments in health intentionally saw a boom of growth and economic growth in the decade after, like Vietnam, for example, or Thailand. There's data that has shown that an increase in GDP happens when you have an additional year of life expectancy among your population. Counterpoint, if more people die at a younger age and there's an increase in mortality, you have a decrease in economic growth. And in places like West Africa and during the Ebola outbreak, the economy actually went into a complete standstill. And even if anything went into a negative direction with years of recovery needed ahead of it. And India actually did a study where they found that in 2005, and given it was a while ago, but you can imagine the repercussions of this as the burden of non-communicable disease has grown, had a loss of $9 billion in GDP from this burden of disease alone in 2005. The World Bank and the Human Development and the UNDP have done a series of studies, and what you're seeing here is in blue, you're seeing countries that received money from the President's Emergency Plan for AIDS Relief, which is the U.S. program that over the last 15 years has put in upwards of $70 to $80 billion into treating HIV around the world. And it was probably it's the single largest investment in any global health effort that has ever been made by a single, in one sort of lump effort. And it's been truly transformational because it actually showed that when you put your mind and your resources to a problem, you can make a significant dent. And we've seen that in HIV at this point. But it turns out that countries in blue that received PEPFAR money actually did better on the Human Development Index than countries that were not recipient countries of PEPFAR funding, which shows that there's been an added benefit to being able to actually treat disease beyond just the health improvement. Health actually we're realizing, has an impact on our security, national security. When I think opportunistically about how do you motivate policymakers to make the right choice, try to motivate them through the things that they've traditionally made decisions on or within their comfort zone. Well, national security is always on the minds of policymakers, and so we should think about how we can help compel policymakers to make the link between health and national security. So it turns out that PEPFAR recipient countries have also seen improved governance, accountability, and political stability. So the World Bank did a study where they came out with a white paper recently that showed that since 2004, PEPFAR countries in sub-Saharan Africa have reduced political instability and violent activity by 40% compared to countries that were not PEPFAR countries or not recipient countries. And then if you look at all the different markers, and again, blue is PEPFAR recipient countries, you consistently have better performance in terms of regulatory quality, voice and accountability, rule of law, government effectiveness, political stability, and control of corruption in countries that were PEPFAR recipient countries. It also just intrinsically makes sense that if a government fails to provide services for its population, there's going to be an undermining of trust about that government's ability to be in control, to perform, and to be able to care for a population that might lead to civil unrest. And I'm not going to insert any political jokes here, but one could. And then, interestingly, when the Ebola outbreak happened in 2014, it was one of the key times in history that the UN Security Council actually called a health issue a global security crisis and really identified the Ebola outbreak as a major issue. And one other time that's happened was the SARS outbreak about a decade ago. A further note about the importance of health. So back in 2000, the Millennium Development Goals were established, and these were a series of goals that were really intended to be markers for progress over the next 15 years, so between 2000 and 2015, established as the UN sort of as the hub and the kind of coordinating center by which countries should begin to make investments and start to mark themselves in progress towards any number of things. And at that time, 3 of the goals were very explicit around health, around children's health, around maternal health, around HIV/AIDS. Well, in 2015, there was a meeting around the Millennium Development Goals to look at progress and to establish new goals. And they came out sort of rebranded as Sustainable Development Goals. So changing the idea of hitting any one target, but a realization that these are goals and targets that we should aspire towards always and forever, that we are always going to want to make progress towards them. And they came out with a whopping 17 goals, 169 targets in total among those 17 goals. And goal number 3 is good health and well-being. So everyone said, okay, health gets its own goal. And some people said, well, it's a step back. It's only one. But arguably, if you look at the Sustainable Development Goal, health belongs to every single one or is connected to every single one. Poverty. Very strong data that links poverty to health. So this is a children's hospital. It turns out that children whose parents die are more likely to grow up socioeconomically disadvantaged throughout their lifetime. If you're under the age of 2 and your mother dies, you're more likely to die yourself. You're more likely to be in a life of poverty. We know that famous study came out in the 1970s called the Whitehall Study that linked poverty to life expectancy in England. And the poorer you were, the younger you died. So there's very clear links to poverty. Nutrition. You can't respond to your HIV medication. You are more susceptible to disease. Your immune system is compromised if you're not well nourished. Life on land. If you don't have access to healthy, nutritious foods and clean food, you can't be well. So no matter which Sustainable Development Goal you're looking at, health is connected to it in some way. This is from worldmapper.com, and this is the visual distribution of global GDP. All the money is north of the equator. This is basically what you see here. This is the under 5 mortality. Money, mortality. And whether you make this maternal mortality, whether you make this burden of disease from, sort of trauma, any number of things, the math will look the same. And the only time it really shifts is when you put non-communicable disease and Russia blows up significantly. But really, most of the mortality in the world is happening in places where the resources are least. What this looks like around specific diseases is that 97% of HIV is actually in low and middle income countries, and 75% of it is in sub-Saharan Africa, as indicated in blue. Non-communicable disease, 80% of non-communicable disease deaths are in low and middle income countries. And maternal mortality, 99% of maternal mortality is happening in resource-limited countries, and the vast majority of it is happening in the 48 hours around labor and delivery. Entirely preventable. In terms of child morbidity and mortality, in 2016, there was a total of 2.6 million deaths under the age of, and 46% of those, 46% of all deaths under the age of 5. In terms of this is the sort of neonatal mortality, and it means that 7,000 newborn deaths are occurring every day. So in 2016, this is the neonatal mortality statistics. For under 5, it is preventable or treatable causes are all complications during birth, pneumonia, diarrhea, sepsis, malaria. And it turns out that it's really more trauma and drowning, especially, that happens that is the leading cause of death between the ages of 5 and 14. And you have a 15-fold higher increase of dying at the age of 5 if you live in Africa from an injury or trauma than you do if you live in Europe as a child. There's regional distribution. When you look at the WHO sort of, categories of death, and I don't know if you can read this well, but the vast majority of deaths are for acute respiratory infections, diarrheal diseases, communicable disease, injuries are next, meningitis, measles, malaria, prematurity, HIV/AIDS, and birth asphyxia. The vast majority of what you're seeing for death between 1 and 60 months is really preventable. And in blue, what you're seeing is the neonatal deaths. And again, prematurity, it's hard to know what goes into that category, but a lot of that does relate to prenatal care and to have access to care. Birth asphyxia and trauma, sepsis, acute respiratory infections. Again, the vast majority of causes of death are preventable. When you look at the under 5 mortality and the rate of dying again, just to highlight, even in the child mortality, there's huge regional differences. Death before your 5th birthday, 1 in 13 children will die, compared to in high-income countries, for 1 in 185 children will die before the age of 5. So how do we solve this? There's been tremendous efforts to solve problems in global health, all of which have been laudable. We've made extraordinary progress. Many countries have been able to march up along and do better in terms of, child mortality, maternal mortality. But in many ways, if you take a step back and see the forest from the trees, we're fighting many of the same battles, facing many of the same problems that we were facing 30 years ago when we decided we wanted to become engaged in this. For those of you who've been to Africa or parts of South America or, even in this country, you can still drive down roads where there is no electricity, no running water, no access to any kind of services. Yet you could pick up your phone and video chat your best friend. The chasm is growing. And the thing that we're trying to argue at SEED is how do we shift that fundamental growth of a chasm to a place where we stop leaving a generation behind. And though we've done all of this extraordinary work, I would argue there's one place that we've never invested with the same kind of rigor and depth of investment, which is in people. And that people are at the heart of a health system. And that no matter how much technology, no matter how much healthcare disruption you have, you need a person to help ground that technology, discover where it can be used again and in a different way, to take that healthcare disruption and apply it differently. We were just chatting before, and the use of telemedicine, it's extraordinary what you can do with it, but it's only as powerful as the person feeding information into that telemedicine communication. So we would argue that people are at the heart of the health system and the opportunities that we haven't taken on yet. This is the WHO's building blocks of the health system. They've broken it down into 6 primary pieces. So you've got financing, governance, the human resources of the health system, information and research, service delivery, products and technology. But each of these building blocks is actually quite complex. You look just at service delivery and we're at a hospital, so this makes sense, right? You've got direct patient care and the aspects of direct patient care that matter to provide quality care to patients. You also have the provider roles and responsibilities, right? Who does what? Do we task shift? What is the nurse's job? What is the doctor's job? Where can you bring in ancillary services to shift time and to provide maybe higher quality? Because, trust me, you want the IV nurse putting the IV in every time. You don't want me. And I think that, and then you've got the quality and efficiency of those services. Are you actually delivering the best services? How does regulation fit into that and sort of affect? But it gets complicated fast. In 2006, the World Health Organization issued a report, Working Together for Health, and this is the first time there's kind of a pause on the role of human resources for health and healthcare delivery. And this graph for me sums it up because it's pretty intuitive, right? although I always argue in Boston this might not be true, where the density of health workers goes up, survival goes up. But no one's laughing today. Am I just falling flat, or is it, usually people, sorry, I'll keep trying. So it's not surprising. The density of healthcare workers goes up. The more you have, the higher survival is. It's pretty intuitive. But it took this particular sort of graph for people to say, oh, wait, people matter. So the same report found that actually there's a critical shortage. At the time the report came out, it was only about 2.5 million. They've just updated statistics. There's a critical shortage of 7.2 million doctors, nurses, and midwives in 83 countries around the world. And it looks like that as a map. So you can see, if you go back to your worldmapper.com, it turns out where there's not enough doctors, nurses, and midwives. It's the places where the burden of disease is highest. And if we don't do anything about this problem, it's going to grow to 18 million by 2035. And the problem is that the distribution of the global burden of disease is actually highest where there are the fewest people. So if you consider Sub-Saharan Africa, for example, which is a quarter of the world's burden of disease, there's only 3% of the world's healthcare workforce. Southeast Asia has about a third of the world's burden of disease and only 17% of the world's healthcare workforce. I think Europe is the only perfect match of regions around the world. And obviously, if you consider the Americas got lumped together, we can try to break that one down. Very different what Canada and the United States has for providers compared to what you see in Latin America or South America. So the reality for a continent like Africa is that it has 70% of the world's global burden of disease, 70% of global burden of HIV, a quarter of the world's global burden of disease, 3% of the world's healthcare workforce, and only 1% of the world's healthcare expenditure with which to address that sort of imbalance. One of the phenomena that has created this issue of the critical shortage of doctors, nurses, and midwives is brain drain. And this is where very talented people throughout the last 30 to 40 years have left their country. They've gone through the public system, they've been trained, and then they leave. Why do they leave? They leave because either there's not political stability, there's not physical, safety, they want good schools for their children, they want better salaries, they want to be a part of an international discourse, they want to practice what they train in and have the tools of their trade. And you can't fault them. It's a human fundamental right to have mobility. But they don't necessarily want to leave. Their life, their family, their culture are in these places. But what's happened over time is that as people have left, it's contributed to this ongoing gap, not just because there aren't enough people have left, but because there's no one left to train future generations. It's also a phenomenon of internal brain drain. This is a slightly outdated slide because there's still the Clinton Foundation on there, but I'm proud to say that I've got us up there too. Because there's also a phenomenon whereby people leave the public sector in these countries because they want job stability even within their countries. And so they will join an NGO or take another job or leave the sector to take a better and more stable job. So it isn't always just leaving the country, but it might just be leaving the public sector. But to highlight again what has happened, there's been this phenomenon by where we've made investments in the last years since that report came out in 2006. We've invested in frontline providers, skilled birth attendants, and community health workers, and we're increasing access to care. But the problem is we've made that initial investment. We haven't invested in the faculty and the highly skilled health professionals needed who sit atop the pyramid, who can ensure they can be the backstop for these frontline providers, who can continue to train these frontline providers, who can train their successors, and who can be the strategist for helping to solve the response and when to these health crises we see. So the Ebola outbreak happened at the scope and scale it happened in West Africa because there weren't enough health professionals to recognize what was happening, to sound the alarm, to help mount the response. And when the Ebola outbreak was over, the first thing President Sirleaf did actually was to prioritize the training of healthcare professionals in our country so it would never happen again, through a 10-year plan that would train the doctors, nurses, midwives, and support services needed to ensure that she had the human resources in the country to prevent something like that. So the leadership gap is real. A colleague of mine typed into PubMed the word HIV and looked at the first author of the top 300 publications that showed up in PubMed. And as you know, the first author tends to be the person asking the question, doing the research, kind of writing the analysis, and driving the publication. And found that when you type in the word HIV, 37% of first authors are in North America, 21% are in Europe, and only 8% are in sub-Saharan Africa, where 75% of the global burden of HIV is. Which means the people asking the questions and driving the agenda are not the people who know what it means to live with this disease day in and day out. I had an intern do it again. The statistics are exactly the same 10 years later, which means we're not closing this leadership gap. There's another problem. There's a specialty gap. There's now a dual burden of disease happening in many parts around the world that are resource limited. You not only have a crushing burden of preventable and communicable disease, but you have a rising burden of non-communicable disease that is happening around the world. And cardiovascular disease is now the leading cause of death, including in sub-Saharan Africa. Malignancy, the third leading cause of death. Chronic obstructive pulmonary disease, the fifth leading cause of death. So we now have this second burden of disease that needs to be contended with, and the systems are not geared up, and people are not being trained to address that kind of disease. One of the other stories I was just telling is that when somebody sees a patient with low blood pressure on the wards, they usually think it's adrenal TB, because that's what they're used to seeing. But it's not anymore. Now it could be congestive heart failure, it could be sepsis, it could be a host of other problems. We need the ability to kind of distinguish these and help train for it. And at the same time, as I pointed out, we still have very high burdens of preventable disease happening. So with all of that background in mind, we tried to help solve for this problem. We tried to address this issue of people at sea. So when Senator Kennedy was running for president, he made an impromptu speech at the steps of the University of Michigan, 2:30 in the morning, to a bunch of students, and just off the cuff, put out the vision for the Peace Corps, challenged the idea, who of you are going to serve your country? Who of you who are going to be doctors are willing to spend your days in Ghana? To be some of the exact words we spoke. With this idea that we would give of our services, give of our talents from the United States to provide the kind of teaching and care and to be engaged in the world, and this idea of outreach and deployment. So as my colleagues and I were coming up with this idea of SEED, realizing that there was a huge amount of need in the places that we worked. We kept seeing people fly in, deliver care, and fly out, but there was never really a shift, an investment in the places that this was happening to sort of empower these countries to have the leadership and agency that they needed, to have their own sort of doctors, nurses, midwives, and leadership to be able to care for the problems in the country in a sustainable way. We started to ask ourselves, how could we create a program whereby we could help provide that kind of capacity and training, fill some of these faculty gaps, build up this new generation that becomes faculty, so that we're creating this sustainable pipeline over time. And I grew up in a house of public service. I'm an optimist about government, and we thought the U.S. government should do this. So the Peace Corps seemed natural as a place to be able to help send Americans abroad in a culturally sensitive and integrated way. So we showed up at a forum marking the 50-year anniversary of the Peace Corps, and we just stood up in the rafters and raised our hand and anonymously asked, what do you think about the Peace Corps sending doctors and nurses abroad to be educators, teachers, to build capacity, and to help change sort of the very technical capacity on the ground? And the answer was yes. It happened to fall at a pretty great time because PEPFAR was just undergoing its reauthorization. And as one of the goals of PEPFAR, they realized that one of the failures to really deliver comprehensive HIV care was that there weren't people to actually deliver that care that were local, who could follow outcomes over time, and that they had to strengthen the health system. And as part of that, they set a goal of training 140,000 healthcare workers, but they had no idea how they were going to do that. So we brought this idea to PEPFAR, and it was a perfect fit and alignment. And we ended up creating a model called the Global Health Service Partnership, which was where U.S. health professionals would serve as faculty for 1 year in partner training site in training institutions. So they would enhance not just educational teaching, because a lot of people had been bringing curriculum, training and teaching and concepts, but nobody was translating that into practice. For those of you that are clinicians or nurses, you know until you actually are in a clinical setting, you can take all the knowledge you want from the blackboard or your textbook. You have no idea what you're doing. My first night on call, I had a patient in AFib with renal failure and hypertension, and I knew how to deal with each one of those individually. I had no idea what to do with all three, and I needed someone to help guide me through it. Medicine and nursing are some midwifery, some of the last great apprenticeships. You have to build your bell curve of patient experience, and that's a real gap in these countries because ministries of health pay you to work in a hospital. Ministries of education pay you to teach in a university. No one was paying to teach in a hospital. So we have to close that theory to practice gap. So volunteers also, you can't be students. No more of this, I'm a U.S. medical student, I'm smarter than you. I've got it down because I come from my system. You have to be fully trained. You had to have clinical experience. You had to have educational experience. And we would embed you for a year into these institutions to teach and train. And the way the models work was sort of like a dorky version of Match.com, whereby sites would end up giving us their needs for clinical faculty. We got a whole host of volunteers that applied to us, and then we would match them up. This is Steve Humphrey. He actually was the chair of his department of cardiology down in Texas, had gone on to spend some time working in Niger with his wife, and he applied and served as clinical faculty. He trained Dr. Pili Chilo, a young faculty who was at MUHAS, who gets over 1,000 new inpatients a day for admission. She's now the acting head of internal medicine and is trying to build a center of excellence around non-communicable disease based at MUHAS. So it became this sort of very positive feedback cycle. But what SEED has done, and SEED has gone on to send volunteers outside of the GHSP, and one of the things I'll talk about is that GHSP actually is, the program is now completed 5 years and it's done. But SEED is continuing to work in the same vision of education and training. One of the things that we focused on that is very different is this idea of empowering through education and training, whereby one nurse will train 10 nurses who will commit to train 10 more, who will train 10 more, and get this powerful leveraging effect. But we've discovered through our first 5 years, the leveraging effect is not just in the numbers we're training. It's in the fact that we can support and train frontline healthcare workers who are out there, give them updated protocols, and help ensure that the most recent knowledge is here. We can help start new conferences on antimicrobial resistance that now are annual national events in Uganda. We have been able to help create leaders who become, and I'll talk about this in some of the stories, but that there's a leverage effect to this kind of teaching and training and long-term partnership that is incredibly powerful. What it looks like in practice is that we have placed over 191 individuals over our first 5 years. And what was very fascinating for us was the increasing proportion of volunteers that stayed on for 2 or more years within this program. So by our final year, 19 people asked to stay on for at least the second year, and we've had people who stayed on for 3 years or 4 years as part of the program. One of the key things about our program that we had in partnership with the U.S. government was that we recognized that many U.S. health professionals carry debt. In fact, the data for physicians is that if you go through public education, your entire education, you will have close to $200,000 worth of debt by the time you graduate. You cannot engage in a public service program with that kind of debt. So SEED committed to raising through private philanthropy because it turns out, well, we have the National Health Service Corps here, does domestic service, and gives you loan repayment. There's no legislation for international health service to do loan repayment, and that was a major problem when we tried to challenge the government to use program. So SEED committed to private philanthropy to raising the funds to provide that kind of debt repayment program needed to ensure that every American who wanted to participate, regardless of background, could participate in the program. And as you can see, we offset some serious debt, including in our 4th year, close to $2 million that year in debt for all ages. Older, sunsetting, retiring professionals on the sunsets of their career who were, had mortgage debt, to young people who carried huge amounts of educational debt. 80% of our volunteers needed support, at an average of about $24,000 for each year served. We worked in partnership with 5 countries, 27 institutions, and 39 sites, from the most rural, where we literally, someone sent me a picture of tumbleweed rolling across it, to urban, like Dar es Salaam, where we were working at the largest national referral hospital there. We worked with both nursing, midwifery, and medical institutions. And we sent, as I mentioned, 191 faculty helped train, not sure what happened there, over 16,000 doctors, nurses, and midwives throughout the course of the 5 years. Some folks we repeatedly trained, but it ended up being over 22,000 mentorship years. We introduced 851 new courses, teaching trainings, bedside ultrasound, skills labs, journal clubs, EKG teaching, all sorts of things. And we saw over 104,000 patients, which is incredibly conservative because none of our volunteers kept this data and they told us that. But we know we hit at least this many patients. And 76% of them always had a trainee at the side because we really insisted that every interaction was about education and training. We also know that the impact of our program was very much around strengthening nursing and medical education. It was an investment in the health system and health system strengthening as we started to train people who went on to take our jobs that sites no longer needed us. It was diplomacy. One of my Ugandan colleagues, when I first told him about this idea, said, what do you think if we start this program? What if we send faculty to your university? And I thought he was going to say, that's great. We have all these faculty shortages. He goes, you know what this is going to do? This is going to change the face of how Uganda looks at America for the better. Not the response I was expecting, but I think it does speak to the power of human connection and the power of learning about other places. It is a low-cost, high-yield premise because for this single investment of starting to train a new generation and helping these countries that often don't have budgets for the training aspect of things, but do have the budget to hire people, you can see the leveraging investment over time. We calculated our costs for about $7 per patient that we saw. We believe it's a change across generations. We also know there's bilateral benefits. So there's data that shows this, and we've started to see this as well. But there's data that shows that when clinicians work in underserved settings abroad, they're more likely to come home and work with at-risk populations in an underserved settings or an underserved specialties here. We also know there's an increased appreciation and understanding of the social determinants of disease. There's a better understanding of how to use what resources are needed when and how to actually do clinical exam, which seems to be a lost art in this country. At least that's what I tell my residents. And so there's real impacts we know that can happen here that are powerful. And 85% of the folks who have served in our program are working in academics now or with at-risk populations here in the United States. So I want to share a few stories about some of the impact that we've had and some of the folks that we have worked with. This is Dr. Esther Johnston. She is our Director of Family Medicine at SEED and our Acting Director of Medicine currently. And the gentleman leaning over is Dr. Aliasgar Kaki, who's a Tanzanian-born physician. So Esther worked with Dr. Kaki and taught him various aspects of family medicine, including neonatal resuscitation. 2 weeks after he had gone on his rotation with Esther, he was on his own rotation, and the team walked by a child that wasn't breathing. And the rest of the team said, that baby's dead, keep going. And Aliasgar said, no, there's a protocol for this. Put his hand on the child, felt the thready pulse, and realized the child was still alive. Used his knowledge, went through the algorithm, and resuscitated the child. And it was so impactful for him that just armed with knowledge, he could change the course of this child's life. That he ended up organizing a training at his institution for 200 other clinicians that could teach them the same protocol, became a master trainer in helping babies breathe, and then has gone on to organize trainings around Tanzania. And if you ask Aliasgar what he wants to do, he will tell you he wants to be a Tanzanian doctor who stays in Tanzania and trains others. Practice improvement in Malawi. This is Mindy Weschler. She's a nurse who worked in northern rural Malawi. So Mindy worked in a surgical and trauma ward and found that nobody was getting their dressings changed. And nobody was getting their dressings changed because the nurses and the patients were also traumatized by the process because nobody was getting appropriately given narcotics or pain medication prior to that process. And part of it was because people were very scared about the use of narcotics and addiction. And the narcotics were kept locked away in a box where only the matron had the key, and if the matron wasn't at the hospital, nobody could actually access the medication. So in partnership with the folks she was working with, they did a training on appropriate narcotics use that was data-driven and evidence-based, and changed the practice on the ward that started to transform the care delivered, reduced infections, better care, that it ended up getting rolled out across the entire hospital. And now there's discussion about rolling it out regionally. And so really using data and partnership and teaching to help impact what patient care can look like. When we left a site after our first year, as two of our volunteers, who are pictured here on the left, left the teaching in internal medicine, the dean of the medical school came up to us and said that for the first time in as long as he could remember, mortality had dropped, and further, for the first time in the university's history, 5 graduating medical students had asked to stay in northern Uganda as health. So we know we can also help with this idea of retention. We can change policy. So this is the Times, which is the newspaper for Eswatini, formerly called Swaziland. And we helped, in Swaziland, we helped start the Family Nurse Practitioner Training Program, which included getting an accreditation exam to ensure that graduates were practice ready and were really qualified to provide high quality care. And developing this exam was such a big deal and was so exciting to the country that it made the front page of the paper, and people were posting it to lampposts all around the country, really. And what basically the article had said was that this is going to save lives. And that we helped institute a policy change that became rolled out nationwide that was widely accepted. We also know we can help build leaders. This is Dr. Kuduku, who is the State Minister for Primary Care and was one of our colleagues that we helped train in one of our first years working in Uganda. And so she has become a real ally and change maker in Uganda now by sort of understanding the power of education, and become a very strong advocate for investing in human resources for health and the power that strong quality training can do for the country. I want to make sure that we save time for questions. So I'm going to jump to our strategy briefly to just share with you how we think about our work now. So the last year and a half has been with its challenges. The program with Peace Corps has closed, in part driven by, I think, a shift in political priorities and funding. So we're very proud of the work that we've done in our first 5 years, but this has given us an opportunity to think through the strategy in ways that we might be able to do our work with, I think, even more depth and more rigor than we did in our first 5 years. And so as we are going forth into this next phase of doing our work, STEED is really organizing itself around a principle call to action that health is fundamental and essential to everything that we seek, that people are at the heart of a health system, and that the global shortage of healthcare workers is an under-addressed and critical crisis, and that through sharing knowledge, we can strengthen health systems and we can save lives, and that the unique value add that we can provide is in education training and partnering with public sectors and governments to help invest in that meaningfully, so that we aren't just seeing health as a social investment, we're seeing it as a fundamental investment for change in this country. So we really envision a world in which a country is strengthened by a robust health workforce, and that is the leading edge of tackling some of the healthcare challenges. And that we will continue to focus on educating a rising generation of health professionals to change the quality of care. We are organized now around 3 principal goals. We're going to continue to focus on education and training. But we're also going to stay very focused on this idea of closing the theory to practice gap. And we are very, very focused on policy, because we don't change the policy environment into which we're trying to make some of these interventions. It's going to be like Sisyphus still. And so we need to begin to make a shift and to use the evidence we're gaining on the ground to shift policy and to shift policies to support what we're trying to do. We're focusing very much on community health and primary care towards the goal of universal health care 2030. We're focusing on emergency medicine. The World Bank has estimated that up to 50% of deaths in low and middle income countries actually are preventable through better emergency services. We want to focus on mental health, which is responsible for 1/3 of the world's morbidity and mortality, and is in some way or another, and is incredibly under resourced. And as well, we need to maintain a focus on maternal, child, and neonatal health. all this to say, as much as I will hold the banner of people, it is complicated, the work that we do. This is Anna McDonald, who is a family medicine doctor who works in rural Malawi. And she was teaching family medicine, and so she was teaching folks how to use the CPAP machine. We're in Children's Hospital. Most of you will know what CPAP is, but it's the external ventilator, so you don't actually put the tube into the sort of breathing into the trachea and in towards the lungs. You use a mask to insert the air in and out, but it provides ventilatory support to the child not breathing. And she had trained people to use this effectively, and they were checking vital signs, the baby's color, and making adjustments, and they were charting the whole thing, and she just stood back and she said, this is it. I don't need to be here anymore. And then the power went out, and the baby died. And Anna, when she told me the story, gave me the punchline of, and then I got to go home and turn the lights on in my apartment. So even if we have people, even if we're making all these investments, there's some really big fundamental challenges that we're going to have to figure out how we're going to fix, which do have to do with resources and these other aspects of things that go into that complicated health system that we're trying to manage. And we have to recognize that there are really fundamental challenges still. So there's huge disparities in terms of resources and where the challenges are highest. Mind you, we have an epidemic of Black women dying in childbirth, though, in this country. So I'm not just trying to peg this on sort of resource-limited countries abroad. There is no us versus them. These problems are real. When you look at what's happening on our Indian or Native American reservations in this country, it's terrifying. Funding for global health is flatlining to declining if you think about inflation. Infrastructure is needed everywhere. We have a capacity gap in many of these countries to be able to change policy. Usually a minister of health is incredibly well educated and trained, but you go one tier down and you lose that kind of depth. There's always a tension between economic policies, trade agreements, and access to healthcare. Attention span. We have no attention span in the day of technology. We expect instant, it doesn't change, we move to the next thing. And we're always looking for quick fixes. These problems have taken years to form. They're going to take years to fix. The urgency of now, though, is putting the right comprehensive fixes in place and starting that path. Progress is possible. In Rwanda, they prioritized health and had some of the sharpest declines in mortality in history. Maternal mortality down 60%, child mortality down 70% over a 10-year span, and the most precipitous decline in HIV mortality ever in history over a decade globally. HIV, good news is infections have fallen, plateaued among adults. We could see that as good. It's not rising. Bad, it's not dropping. But we are on the cusp of having an AIDS-free generation born, which is very exciting. We have more on treatment as long as we can keep funding, and God bless our Congress that does seem to be holding the course on that. Never thought I'd say those words, but I will in this case. The Ebola vaccine, it turns out when you put your mind to it, you can develop a almost 100% effective Ebola vaccine in a year and a half. But we are at a watershed moment. There's a lot at stake. And we need to really ask ourselves, what are we going to do? Because the truth is it's changeable if we choose to make it so. So with that, thank you very, very much for your time this morning, and I look forward to questions. Oh, thank you.
Thank you so much
very much
for sharing your experience.
Thank you.
It's very powerful. And I want to open it up to your questions.
Yes. Okay. I can also repeat questions then.
Okay, thanks. Hi, my name is Chantel. I served as a Peace Corps volunteer in Zambia. And one of the things that was frustrating for me as a volunteer was reporting our numbers. There wasn't a lot of space to report on, like, how effective and sustainable the things we were doing. It was just like, how many people did you talk to? So I'm curious about how you guys track your effectiveness and sustainability after you leave.
That's a great question. Tracking, So it's interesting because when we were in partnership with Peace Corps, we suffered a little bit from that too, because there were certain things we were allowed to study and certain things we weren't allowed to study. And so there's a lot of outputs up there. I'll be honest with you. Numbers trained, there's a certain, it's exciting, but the impact, the true impact and kind of qualitative change for the things we went after. And so at SEED, we did that on our own. So part of it was through more comprehensive questionnaires. We were actually allowed to do our own monitoring evaluation to some degree, in that the design of the program made it difficult to maybe capture some of the data that we wanted, but what we would do is we would ask people to kind of report out on certain testimonials and to report into certain categories. So we really looked at empowerment of trainees in terms of confidence, in terms of actually we did some on skills, so skills gained, and what we couldn't measure, for example, is health outcomes. We were never powered to be able to do that in the right way, and that's something we're going to do in the next 5 years with our new design as we build out very structured partnerships, and we look over 5 years to go towards very clear metrics. So not only how many people we've trained, how many people do we graduate, how many people stay in the system, what are in the places where we can have a close enough system on health outcomes, we're going to measure the health outcomes. So have we actually seen a drop in neonatal mortality when we've done updated protocols on, breech birth delivery and things like that. So we're going to be very targeted on things like that as well. So we've tried to capture some of the qualitative data. We did actually hire third parties to help us look at graduate tracking and to look at some core case studies on quality of education, on on empowerment, and sort of like what the kind of the culture of learning is and an environment of learning, to see if we've had an impact on that. But it was an imperfect system because of the way we were designed with our partnership with Peace Corps. We were sending a lot of people to a lot of places, and we weren't powered to necessarily institute the kind of change that we're going to be now that we're targeting ourselves a little bit more. But I can understand that frustration, because the flip side of it is our volunteers are always like, we're reporting too much, and I don't have time. I'm not going to fill this sheet out. I don't know. I saw 10 patients. And I'm like, no way. There's 80 on the ward today. But that's always the frustration. Yes, question here.
Thank you for really an extraordinary talk, very motivating. One of and I really want to applaud the whole SEED vision of building local capacity and training the local workforce. One issue that sort of comes to my mind, though, in this whole domain is that building that local capacity is oftentimes dependent on technologies. A simple example, you can diagnose mitral valve regurgitation, but unless you have the capacity to replace the valve, you can teach radiology, but unless there's an MR scanner, building that local infrastructure seems to me to be a secondary challenge and a secondary effect. How does SEED deal with that issue of not having the toys that the local clinicians need to practice their art at a high level?
So I think twofold. Where we are, the way we're designing now is actually to help address that to some degree, which is that we will send educators to be faculty, but we come with a package of services now. So trying to understand what are the major barriers, at least to the teaching and training aspects of things, and to the care delivery so people can practice what they train in. So we will become advocates now for the government or for the public sector or for other partners to help fill that in. And our partners have sort of said to us, we need you to be the voice, because if we speak up, and this is the truth, they fear being punished for trying to be a thorn in their government side. And so we can play a role, I think, as being advocates around some of that issue. In other ways, we can help write grants or look for opportunistic partnerships. So we had a partnership with GE, for example, where we used handheld ultrasound. We got handheld ultrasounds donated, and then we brought the education and training around the handheld ultrasound, which has become a very powerful diagnostic tool, management tool, and teaching tool. And so there are appropriate cases. Are we going to buy a CAT scan machine? No. I mean, at the end of the day, too, these governments have to decide or find the funding, or the IMF has to stop telling Malawi, you can't hire healthcare workers or make these investments in health. But that's also the power of why we design ourselves around policy, too. If we can change the value of health and start to show these small investments have huge kind of gains on the backside, it helps empower the countries to make those investments also, because this has to be sustainable. We can't be the constant source of equipment. And there are people who donate equipment. I think the thing that's been frustrating for me is I got offered an entire container of incredible equipment, and then I was told I had to pay the $25,000 in shipping. And I just, we were like, this is, we rock in a hard place. I don't have 25, you're just sort of, it's just a fine balance. It's not a perfect system, but there are other people who are doing some of that equipment and infrastructure. But at the end of the day, for these countries to be functional, they're going to need connectivity. They're going to need a stable grid. They're going to need clean water. And I think that, but that's going to have to come from the government. But if we can help, create the connections for that to happen, I think that is the role we can play. But it's every day I feel like it's, robbing Peter to pay Paul in some capacity, or I'm in a Sophie's Choice, because the need is endless. And we just have to do our best to create the network that we're all aligned in and working together. I mean, Peace Corps is still doing education training in these sites, in the countries that we're working. Some said, aren't you angry that they're still doing this? And it's you brought the idea, and like, you guys are, and I said, no, because there's so much need. Thank God they're filling some of those faculty gaps. So we got to be a team and think about how we canvas to do it together.
One more question.
All right, I have a question. My name is Camilo Gutierrez, I do emergency medicine, and similar to you just mentioned, over the last decade or so, we've been working with governments developing acute care systems and emergency care systems. My question for you is, if you were in CUGH in Chicago a couple of weeks ago, there are more than a handful of organizations like yours engaged in the same discourse. How do you propose to disrupt the silos that are within our own country? I mean, Boston is Partisan Health, it's your group, there's a ton of different groups. How do you think we can disrupt or engage our own stakeholders to further be able to engage the stakeholders abroad to show that we're going the same message, try to change the systems at some point there?
So it's interesting, because I feel like a lot of my colleagues with whom I work in this field are, there's increasingly sharing of knowledge. But if we're really candid, what is siloing us is funding. Because everybody is trying to fund their own shop, and people get territorial. And a lot of people have said to me, why don't you all just go into this together and try to get like the master mega money? And I think that's the right idea, and people are doing it. Community health worker groups are coming together around that. I think, and so I think there is a power to doing that. But I want to be careful, because it's not the concept of our work that I think is dividing us, or kind of the principles of our missions that is dividing us, because I think we can see the opportunities to work together. I think it's the fact that we're fighting over limited funding. And I think that what needs, I don't have an answer for that challenge. I don't. I'm not going to stand up here and pretend to be holier than thou and say, take that funding. I've got a staff and I've got 26 sites. And, that said, I am wise enough to know that there is nothing to go around. I was talking to a funder of ours last night, and I could tell somebody else who gets funding from them was antsy that I was speaking to him. And he looked at me and he goes, I'm going to fund them too. What is their problem? And, but I think it's important for us to just be honest about it, because I think if we can defuse that tension a little bit, it'll be easier for us to kind of align and to think about, because I actually now send funders who say no to me. I'm like, oh God, but you're perfect for them. Because again, the need is bottomless. So if we can stay rooted in our joint mission, which is, I think, a complete, just frustration about the status quo still happening in the world. If we can stay united in our common ground on that, I think we can think about ways that we can really work together. Because I can think of ample opportunities to work with people if we could just figure out how to fund it together. And I am only stronger for being in a network. And, there's 83 countries around the world. We're not getting into all of them. I can't even cover the base of the countries we're in now, which is why I welcome Peace Corps help. So but that to me has been the real silo, is the defense of how we keep ourselves alive. And I think that We do have to ask ourselves some hard questions about ways that we could come together to get more funding, and to challenge ourselves to not be so tied to our individual missions, to not see opportunity. Doesn't mean you should bend yourself for money. I don't believe in that either. But I think that we can also realize sometimes that we may not be always thinking about things, and there's opportunity to learn more and things like that. I don't know if that totally answers your question, but it's an important one.
Well, thank you. I know you have to run. So thank you again for inspiring our institution to keep investing in global health.
Thank you, everyone.